The final presentation of the morning session is going to be given by Professor Monica Slavin. She's a Chief Investigator on CRE Reduce, and she's an infectious diseases physician who's internationally recognised for research in improving prevention and treatment of infection in immunocompromised patients. She's got extensive experience in designing and conducting clinical drug studies in the transplant setting and will provide scientific input into the Reduce study design. Her major research interest is in infections in the immunocompromised patients, as I mentioned before, particularly those with cancer and undergoing transplantation. I'll invite Monica up now. Thank you.
Okay, thanks, Jason. It's a great pleasure to be here in sunny Queensland and to escape from the Melbourne winter. But it's also a really great opportunity, and I thank you and thank Jason to have the chance to talk about fungal resistance. We've heard a lot today about antibiotic resistance and bacterial infections, but for the immunocompromised patient, fungal infections are equally, if not even more important. So we don't actually have a problem with antifungal resistance at the moment, but I think we've got all the factors in place, which means that we could be heading for severe difficulties with antifungal resistance in our most immunocompromised patients. So I'm going to talk a little bit about what's going on in this space at the moment. And we can see from this slide showing us who are the immunocompromised patients that we see in our hospitals. And we can see that those that are undergoing allogeneic stem cell transplant, treatment for leukemia, lung transplantation and other solid organ transplantation are really at high risk for invasive fungal infections. And these patients are more likely to die from an invasive fungal infection than to die from a bacterial infection. Because of this high risk, these patients are generally on antifungal prophylaxis to prevent them from getting a fungal infection. But they also, where there's a suspicion that they might be getting a fungal infection, also get empiric antifungal therapy, so get additional antifungal therapy on top of the prophylaxis if it's thought that they're developing an infection. And from our data in Australia, we can see that about 20 to 30% of patients who are getting treatment for acute leukemia or a stem cell transplant will require empiric antifungal therapy on top of their antifungal prophylaxis. So there's a lot of antifungal usage in this group of patients. We also know that we're not very good at diagnosing fungal infection. And this is some data from a hospital in the UK who actually looked at their high-risk haematology patients and said, if we use one test, how many fungal infections do we diagnose? And you can see there that with one serological test, they could diagnose 11%. And this progressively increased if they used more diagnostic tests. But these tests are expensive and actually not in routine clinical use. So you can see that we might be missing from this slide at least half of our fungal infections. We're just not diagnosing them. We're not able to recognise them. And that's another driver for the use of antifungal therapy, because you're scared of not recognising the infection and actually putting your patient at risk of dying. This is some data from Australia where we did a survey of many of the transplant centres in Australia and New Zealand, and what kind of tests did they have available to them. And what we can see from this, we really tried to look at how many of these sort of new diagnostic tests were available. And in the last column here, we can see therapeutic drug monitoring or antifungal levels, which are also helpful in treating patients. But what we found that many of these centres had to send these tests away, and the results weren't available immediately. And in some cases, they would take up to more than 7 days to get back. So you can see that we're in a very difficult position in trying to diagnose these infections when we don't have the tools immediately available to us. Another factor driving use of antifungal agents. In our hospital, we did manage to reduce our antifungal usage, which was really skyrocketing to about over $1 million a year in one hospital. by actually introducing these diagnostic tests. And when there was more certainty about what the diagnosis was, we were using less empiric or undirected antifungal therapy. The other factor driving the use is, of course, the poor outcome of these infections. As we can see from this slide, which is from that UK group who looked at new diagnostics, here's their overall survival for their haematology patients over 2 years. Here's the survival for patients who had a fungal infection, those who were thought to have a fungal infection, and those that didn't have a fungal infection. So we can see much poorer survival in those who had a fungal infection. We know that it costs a lot of money to treat a fungal infection, and these are some data from around the world in pounds and dollars and US dollars, all confirming the same thing, that it costs around 80,000 Australian dollars to treat one fungal infection. So again, this is the impetus for the use of prophylaxis and for the use of early empiric therapy. But again, we're using a lot of antifungal agents in these patients. The other area where fungal infections are really important is in the intensive care unit. And a recent survey in Victoria showed that Candida is now the second commonest cause of central line associated bloodstream infections in the ICU, second only to Enterococcus. We heard about the rise of Enterococcus, and it really was proven in this survey. Candida is not decreasing. Some of the other causes of bloodstream infections, such as Staph aureus, are decreasing through very targeted programs of hand hygiene and various infection control interventions. But we haven't really made an impact on Candida, and Candida is now the second leading cause of these catheter-associated bloodstream infections in Victorian ICUs. What is also interesting is that the type of Candida we're seeing is changing, and this is some data from studies in Australia over the last 15 years. And what we can see is that the type of infections caused by Candida glabrata, and this type of infection is important. It's a strain of Candida which has a propensity to become drug resistant and is also intrinsically resistant to many of our antifungals. And we can see that the proportion of infections over the last 10 years in Australia, bloodstream infections caused by Candida glabrata, has really doubled. And this is a signal, really, that we do need to be concerned about drug resistance, because Candida glabrata is the strain that tends to have and tends to develop drug resistance. We're also globally in a bit of a problem with our antifungal prescribing. And while there haven't been a lot of surveys and a lot of attention, John Turnage showed us all the data about antibiotics. We don't have as good data about antifungals. But one audit in France did show that about a third of antifungal prescriptions were considered to be inappropriate in dosage or in actually what they were indicated for in one French hospital. And although there wasn't really a clear association with outcome, there was perhaps a hint there that those who had the most appropriate prescribing had the better outcomes than those who had inappropriate antifungal prescribing. And of course, Jason Roberts and his group have done some work in the ICU showing that about a third of patients receiving fluconazole, a very common antifungal used to treat Candida infections in the ICU, with the doses that they were given, would actually not have been able to have reached the targets that were required to successfully treat the infection. So this is a bit of a clue. There's not a lot out there about antifungals, but this is a clue that we could be doing a lot better with how we prescribe these antifungals. So I've showed you that there's really a drive to prescribe them. They're being given very sort of aggressively to our transplant, our leukemia, our haematology, and also in the ICU. But we actually don't have the good tools to refine their prescribing, and I think that's an area that will encourage the development of resistance, even though we're not seeing it currently. Globally, we are seeing increased resistance to antifungals, and we saw a little clue of this in our Australian Candidemia study surveys, where now we're seeing a proportion of a very rather innocuous candida called Candida tropicalis in bloodstream. We saw no resistance of it back in 2005, and now we're seeing about 19% are resistant to our very workhorse antifungal of fluconazole. We're also seeing resistance in Candida glabrata. We're not seeing echinocandin resistance. Echinocandins are the new kid on the block to treat antifungals and are very effective agents generally given now as first-line therapy. Luckily, we only saw one Candida isolate over our survey that was resistant to caspofungin, but I don't think we can sit on our laurels there and say we're not going to see any problems, because globally what we know is echinocandin resistance has emerged now in Candida species, and it's that problem bug, Candida glabrata, that I was telling you about that seems to have the highest rates of resistance. And this is some data from one hospital, Duke University Transplant Centre in the US, showing that over the last few years, they're seeing up to 15% of their Candida glabrata that are resistant to the echinocandins, our new and our best drugs against Candida bloodstream infections and Candida infections. It's interesting to think about, when did they start using the echinocandins? Well, they were licensed around here back in 2001. For us in Australia, they were licensed around 2005 and started to be used more widely after that. So it may only be a matter of time. We've got these drugs later. We've been perhaps using them less frequently and for a shorter duration than what's been experienced in the US. We are seeing increasing rates of Candida glabrata. We are seeing increasing antifungal prescribing. So I think we've got the perfect storm where we could well be seeing resistance in our patients with Candida in the next 5 to 10 years. What about Aspergillus and other fungus? That's very important in the immune-compromised patients. And you can see that, unfortunately, we're now starting to see azole resistance. Azole are common drugs that we would use to treat Aspergillus, and it's being reported as a global phenomenon now. And recently reported from Australia, we've seen a couple of cases of Aspergillus that are resistant to the azoles. It's not a widespread problem in Australia, but it has been noted. And interestingly, tying back to some of the themes that we've heard this morning, the One Health theme is important in the global emergence of azole resistance. It was really first reported in the Netherlands back in 2009. So it's something that's really emerged just in the last 5 years or so. And there's a particular genetic marker in these azole-resistant Aspergillus, which has been linked back to agricultural exposure to azoles. Azoles are very widely used as to help crops grow and to stop fungal infections attacking crops. And it's postulated, although it hasn't been definitely proven, that these azoles being used in agriculture are the ones promoting this resistant strain of Aspergillus, which was really not been seen until the last several years, and which has been seen in patients, frighteningly, who've never had any exposure to antifungals, who just seem to have acquired this resistant isolate from the environment. So it's really quite sobering, and I think it teaches us again that in medicine we really have to look beyond what we're prescribing in the hospitals and what we're prescribing in the community to what's being used in agriculture and in other areas. So that's all a bit sobering. So I think although we don't have the problem of antifungal resistance, it is on our doorstep, and we really need to start thinking about what we're going to do to prevent it from emerging. I suppose we're in one slightly better position than with antibiotics, that we have this window of opportunity now to do something before we're starting to see widespread infections. And I think one of the key factors is investing in good diagnostics. We're never going to be able to stop this widespread use of antifungals, this major concern about patients dying and how much it's going to cost to treat the infection, unless we can actually clearly diagnose it and pick it up early. So I think in Australia we are going to need more investment in diagnostics. We're going to need to continue looking and doing surveillance for resistance, particularly in Candida Glabrata and in the Aspergillus species. And we really urgently require studies, and this is where this CRE comes in, is going to play a major role in optimising our dosing of antifungals, because we really know very little about optimising dosing for all the conditions that we've heard about, for patients in the intensive care, for patients who are neutropenic, and all of these situations may require significant changes in the way we dose antifungals, but we don't know. And I think that's very important. And the other area is education and antifungal stewardship programs. Again, something that this CRE will be able to lead the way on. And as I showed you from the data about how antifungals are prescribed, something that's sorely needed. So I'll finish there. Thank you.